αυτά από μένα. Έχουμε ένα ενδιαφέρον, πιστεύω, περιστατικό. Κάνουμε minimalistic TAVR, αυτό θέλουμε να δείξουμε. Μερικές φορές βέβαια ξεκινάμε σαν minimalistic, αλλά δεν είναι minimalistic, γιατί χρειάζεται να βάλουμε ένα ηλεκτρόδιο βηματοδότη. Να παρουσιάσω πρώτα την ομάδα. Δίπλα μου η Παναγιώτα, η Γεωργιάδου, μέλος της ομάδας το Structural. Έχουμε τον Παναγιώτη τον Φτίκο, ο οποίος παρέχει την αναισθησιολογία. Είναι η Ελένη, η αναισθησιολόγος, η βοηθός, η νοσηλεύτρια αναισθησιολόγος. Έχουμε την Λιζέτα, την Αγγελική. Έχουμε την Ματίνα την Παπαγεωργίου, η οποία είναι η ψυχή του τμήματος Τάβη. Έχουμε την Έλλη και έχουμε τους δύο πολύ καλούς συνεργάτες από τη Medtronic, Βασίλη και Στέφανο. Οπότε, Ηλία, μπορείς λίγο να μας πεις τι ακριβώς είναι αυτό το περιστατικό? Είναι ο Ηλίας ο Κοσμάς.
Καλημέρα και από μένα. Να χαιρετήσω με τη σειρά μου το συνέδριο και να προχωρήσω στην παρουσίαση ενός πολύ ενδιαφέροντος περιστατικού, η οποία αφορά μια γυναίκα 87 χρονών, 1,58 ύψους και 67 κιλά, με προοδευτικά επιδεινούμενη δύσπνοια προσπαθίας. Από το ιστορικό της, όπως μπορείτε να δείτε, αρτηριακή υπέρτηση, λιπιδαιμία, χάπι, υπνόμενα βρόχο διασταλτικά και κρεατινίνη 0,8 με αυξημένα σκορ κινδύνου. Από τη στεφανιογραφία δεν βλέπουμε σημαντική στεφανιαία νόσο, ενώ όσον αφορά τον υπέρηχο, έχει καλό διατηρημένο κλάσμα εξωθήσεως και σοβαρή στένωση αορτικής βαλβίδας με gradient 79 μέγιστο και 54 μέσο, με μια ταχύτητα στο 4,45 μέτρα ανά σεκόντ. Και βλέποντας τις εικόνες, όπως είπαμε, βλέπετε ότι η στεφανιογραφία δεν ανέδειξε σημαντική στεφανιαία νόσο. Βλέπετε τη δεξιά στεφανιαία αρτηρία με μια 30% στένωση δεξιά στεφανιαία και ακολούθως το αριστερό σύστημα με μια που έχει φυσιολογικό στεφανίο. Βλέπουμε λοιπόν και αορτογραφία με μια μικρή ανεπάρκεια της αορτικής βαλβίδας. I will turn to English in order to be better understood. So here you can see the screening echo, AVA 0.8, and elevated gradients. And on the right, you can see the aortic valve. So here is the left ventricle, hypertrophic. And as for the CT angiography, here you can see the measurements. We have promising femoral access with mild calcium and very good coronary ostia and sinus of Valsalva height. And here you can see some more pictures. The calcium in the aortic annulus, the annulus is 38, very good coronary height and hypertrophic left ventricle. And as for the femoral access, we have promising dimensions and no severe calcification with a mild tortuosity to the right femoral artery. So our choice here is the 26 millimeter Evolut valve, and the heart team of our hospital decided that transcatheter aortic valve implantation should be the optimal strategy. So, Dr. Iakovou.
So this is, let's say, a straightforward case. We don't anticipate any issue regarding the valve implantation. Of course, it's highly calcified lesion, and maybe we could ask the panel. Danny is there, and Arik, and maybe and Chaim, or Erika, Mariano. Maybe we can. What will be their approach? Would you predilate with a non-compliant balloon or a regular balloon? What would be your take on that? And you have a mild elongation as well of the PR. It's like 180 milliseconds. So do you think it's sufficient enough to place a transvenous pacemaker or not?
It's a pleasure to see you on the screen. You've been with us in the room like 5 minutes ago. I'm not sure how you did it, but it was very impressive. We thought for a minute that it's live in a box, just that you'll understand, because it couldn't be, we couldn't imagine that you are there. So it looked like a very calcified valve, right? This is clearly you need to prepare the valve well before bringing the TAVI device, right?
Yeah.
Do you have calcium score, or do you have some numbers here?
I'm not sure we have these numbers, Ilya. Do you have the calcium score?
It's probably like 7,000. It's not going to be like 2,000 here.
It's about 2,800.
So maybe it's a mistake in the calculation, but the number that we have is 208,000.
Yannis, hi,
Yes.
it's Eric. I don't think we need a number. We see it's pretty calcified, and I want to tell you something, and maybe I'm wrong. But I think that
you are never wrong.
No, maybe I'm wrong. But we have learned from, and I have a déjà vu, and I will mention it in my talk. Makes me a déjà vu of the stents. The lesion preparation becomes more and more important. And we have data today that it's important for the durability, it's important for the health, it's important for the clinical event. And I think that from case to case, I'm being convinced more and more that pre-dilatation is mandatory, not only in self-expandable valve, but in balloon expandable as well, in order to prepare. We've been always accused by the surgeons, justified, by the way, that they are doing the modification by taking the old valve out. We cannot take the valve out, but at least we can prepare it as much as we can. And I, by the way, always prefer to do a pre-dilatation than a post, because the post-dilatation is with the valve inside and with the danger of pop-up, etc., etc. So if you're asking me, I gave a long answer. Yes, I would dilate.
Yes. You remember the old times. So for a certain period of time around the direct study, some people, including us, we were including patients enrolling patients in this study. So we were doing some direct implantation as well. So I think, but now it's clear that we need to pre-dilate. So in this,
Yannis, hi, it's Petros Dardas.
Yes.
Congratulations for your case. Another remark I would like to make is that there is some LVOT calcium going from the left side. So we need to be careful when there is LVOT calcium and perhaps not so aggressive. And I think that in this case, and I don't know your practice, but in this case, a self-expandable valve would be preferable than a balloon expandable valve.
Yes, so we noticed that, and that's why we will pre-dilate with a non-compliant balloon. We don't normally do that. We start with the semi-compliant balloon, but in this situation, just to avoid the extra steps, maybe it would be sufficient to do a pre-dilatation properly sized according to the mean to the mean diameter as calculated by the Trimensio. So we can take it from there. So we have, if you can see here, we have placed crocodile clip in the right femoral, and then we'll have another one at the end of the shaft. So Jota, let's go. So feel free to discuss and maybe give some advice.
What number of balloon are you using there?
It's a true balloon, 22 by 40.
22.
So you can appreciate also that the
so you go by the average? You go by the average with a non-compliant balloon. Okay.
Yes. So you see the pigtail, it's hovering above the aortic annulus because it cannot be better placed. But I think we can identify, the area of interest. Okay, let's go. Πάμε 100. Inflate. Όλα και όλα. Ωραία, τέλεια. Deflate. Okay, pacemaker off. So you see there is some resistance in the non-coronary area. Danny, would you further predilate, or you think it's sufficient, this one?
Oh, can you repeat the question?
Would you predilate more, do another round of predilatation, or?
Yeah, I do double taps also with pre-deals. If I'm already there, it's not going to change the sequence of the case.
Yeah.
You're already there with the balloon.
Yes,
it's
so
required.
we are not 100%. Yes, we're not 100% with the expansion of the balloon.
Can you show us the dilatation again?
Yes. You see, there is still some resistance at the non-coronary area.
On the non-coronary.
Maybe we'll do it again one more time. Jota, do you agree? Yep. Okay. So, she agrees. Tipis.
So it's a true balloon?
Yeah, it's a true balloon.
No, unfortunately, in Israel, we don't have true balloons as non-compliant. We have Atlas balloons, which they inflate and deflate. It takes them much more time, unfortunately. In the US, this is the main non-compliant balloon, true balloon. Hopefully, we're going to get it.
I think it's the only thing that Greece has and Israel doesn't have. Okay. Πάμε 188. Πάμε 188, πες με καιρό. Ωραία, inflate. Okay, μπράβο, Γιώτα. Deflate. Okay, pacemaker off. Πήγαινε 80. We just let it breathe a little bit. Pace a little bit higher. Okay. So there is some AI probably, but now it's getting better.
Yeah.
I think we'll just proceed with the valve, and then we'll take it from there regarding post-dilatation or not. And there is some rhythm disturbance. We see some prolongation of the QRS. And there is some elongation as well of the PR. So at this point, would you place a transvenous pacemaker, or you just proceed with the procedure?
Oh, it's not a block, right?
Yeah,
you can wait.
Yeah, we'll wait a little bit, but I think it's getting better. And then we can always place it later. Okay. Okay, good. Let's go. Πάμε, το βγάζουμε. Σου βοηθήσω. This is Arik Finkelstein's trick. So when we try to remove the balloon, Arik shows us you need to go forward in order to go backward sometimes. But this is a general lesson in life, Arik, isn't it?
It is what?
No, I mean, so we while we're retracting the balloon valvuloplasty, sometimes you always have resistance when the balloon goes into the sheath. So, as you suggested in the past, you needed to go forward with the balloon in order to accommodate it in the sheath. So,
that's right.
Yeah, yeah. Okay.
So it's a Evolut FX Plus, we assume?
This is a FX. This is Evolut FX 26. So the cost of FX Plus, it's a bit higher in Greece. So it's saved for the younger patients.
The patient doesn't have coronary artery disease, right?
No,
so it's okay.
and also we try to
88.
be to be sensitive on the alignment of the valve. We're still trying to respect the steps. So can I have the? Yeah.
So you switch to over-the-wire pacing almost routinely in your practice?
Yes, definitely. We do 95% of the cases like that. But in approximately 10% of the cases, we need at the end of the procedure to place a transvenous pacemaker. I think it's worthwhile. So since we are using the FX, we are even more meticulous in how to place the valve. We are working on cusp overlap, and you see Dr. Georgiadou is holding on 3 o'clock the valve, just retract a little bit the wire. So maybe we'll need to start a little bit higher, like here. And so I have been informed that this is an FX Plus, so maybe so we did some exception for the conference. Okay, so let's pace at 80. So the valve looks pretty stable at this time, and the patient. So maybe we can start from here, and we'll let it slip a little bit.
So this is the cusp overlap view,
Yes,
I assume, right?
This is
so
the cusp
we have
overlap.
the non on the left side and the right
yes,
and the left together
the
on the
pigtail
right
is
side.
around 4 millimeters above the annulus. Okay, we can start. Yep.
You have a beautiful landmark of the annulus. You don't need injections there, you see. You have a painting of the calcium.
Yep. But maybe we'll do, since it's, you see, we're a little bit high, but I think we'll go down. Yeah. Yeah. Λίγο το σύρμα μέσα. 120. 140.
It went down a bit, right? But still okay.
Let's see. Okay, stop. Πάμε 80.
Yeah. We're not perpendicular to the valve. Maybe we can correct and understand.
Yes, maybe we'll correct. But maybe we can take a shot here. So it is, but it's not that low, I think, the plantation. So
No, have a look, Yani. The patient is stable, so you can show us. You see, as Danny said, it's not perpendicular, right? Now you see 3 dots of the stent, of the valve.
Yes, but now we will correct and then we'll...
But if you looked before, you saw 2 that were below the annulus. One was pretty high, and when it's going to correct it, it's going to be somewhere in the middle, and that's what you see now. Now, this is LAO-caudal probably, right?
Yes, yes.
Right, I'm right? Now, LAO-caudal always gives you overestimation of the height, meaning that if in LAO-caudal you see that you are in the 0, it means you are good.
Yeah.
If it's LAO-caudal, shows you it's the mirror of RAO-caudal, of cusp overlap, okay?
Yes.
So it shows you what you see here is higher than what you are. So I think it's pathognomonic. If it's on the 0 and on injection you don't see a full AI, you're perfect.
Yes, definitely. Let's see. Make a shot again. So in this projection, we see also the apposition in the left cusp. It's a relatively shallow, I think, the plantation. Would you go a little bit lower, Arik and Danny?
I just want to make sure that you are LAO caudal now, right?
Yes, it is.
Go now to three. Can you go to three cusp view?
Πάμε στο three cusp, λίγο. Three cusp, όχι στο
So
So it's 36, 28. Maybe we're a little bit low.
Show me three cusp view. I want to show that.
Πάμε three cusp view.
the patient is stable. We can take pictures and assess it from different angles. There is no need to rush into decision.
You see that? This is the three cusp view.
Yeah. This three cusp.
That's the implant.
Okay, this is the three cusp. So you don't have a lot of parallax, but
Can
let's
correct
see.
for perpendicularity, maybe.
Yeah. Πάμε λίγο να το διορθώσουμε εδώ που είμαστε.
So the LO caudal showed you that you are like in the zero. No, you're not in the zero. You're deeper than that. You see?
Okay.
Now it's not going to stay like this. It's going to correct itself.
Okay. Ωραία, καλά είμαστε εδώ.
Yeah, maybe
So
another injection in like
between. So it's like a caudal, but so it's a cusp overlap a little bit corrected. It's a AP caudal, let's say. Πάμε λίγο πιο caudal, μια ιδέα, λίγο. Okay, άστε εκεί, ωραία. Να γράψουμε. Πάμε. I think maybe we're a little bit too high.
Yeah, it's probably,
what angle is this?
It's minus a bit. It's
What
like,
is this?
Yes, this is a corrected cusp overlap.
It's like around
This is
80.
RAO caudal?
This is apicaudal, yes. Almost apicaudal. It's Aleo 1738. So why don't you go back to the cusp overlap? Maybe we place the valve a little bit lower.
Yeah, you're a bit in a minus in the non-side.
So it's
Since we have time to discuss and it's important, you're going to do what you're going to do, of course. But I want to tell you something, Vasily. Yanni, this is not too high. This is perfect. However, since it's not fully dilated, there is a very good chance that you will have to do a post-dilatation. And if you will have to do a post-dilatation, you don't want it to be that high. That's the only reason. Otherwise, I'm telling you, you're in a perfect place. But
and what we also see, it's not fully expanded in the non-coronary.
Exactly.
So maybe we can take advantage of the opening force of the evolute and then retract and then reopen it. What do you say? I think we can do that. Πάμε 100. Ναι, 100. Okay, let's go. Let's put a little sirma. Okay, maybe it's more centered like that. Maybe you can stand from here. Με 120. Να γράψουμε. Έλα την Ωραία. I think we are okay, a little bit lower than before, but let's see. Πάμε.
More centered this time, Yannis.
Yes, a little bit. Okay. Okay, το κρατάς. Έλα να γράψουμε. I think it's almost the same, maybe.
That's a fraction lower. It's massive fraction lower. It's more centered.
Yeah.
You see what I meant before? There are two dots below the annulus, one above, and at the end it's going to be somewhere in between them.
Okay, let's see. Πάμε. It's almost maybe a couple of millimeters, 1 millimeter lower from the left side, and from the right. I think it's a better position, but let's see. Πάμε στην cusp over. Πάμε στην 3 cusp. So we'll go to 3 cusp, and then we'll take the parallax out, and see what. Okay. Πάμε λίγο πιο κοντά. Okay. So this is kind of 3 cusp, a little bit corrected, but now it's very close to what we had. Okay. Να ξαναγράψουμε. So there is AI, of course, on the left.
The position seems good. It's only a bit underexpanded, but the position looks nice and high. Yeah. And it's not deformed, it's just a bit underexpanded, as we can expect from that calcification.
Yeah. So maybe if there is a case of definite post-dilatation, maybe we should place it a little bit lower, you think? Just for safety? Would you do that?
If it won't be a live case, I say no, but it's a live case, so don't take a chance.
I know your opinion about the live cases.
I tend to believe that the frame is stuck on the calcification, and unless you have a lot of stored tension, it will go nowhere. This is, okay. It is where it is.
No, the position is perfect, Yanni. I'm saying the position is perfect. The only question is whether we are a little bit scary of post-dilatation in a position like this. I'm not sure. I don't think so, but you take your decision. Yeah. It won't be a mistake to put it at 2 millimeters deeper.
And maybe we can do. But on the other hand, of course, we have a lot of hypertrophy on the ventricle, so maybe there's some interaction there as well, because we will not go a little bit lower. But yes, we can do one more try. Yota, what do you suggest?
Maybe to deploy in an angle that will be perpendicular to the volute.
Yeah.
Because it comes in a weird angle. Like this.
So we'll go again to cusp overlap. Let's try to open it a little bit in a guess.
Yeah, maybe to make
In the meanwhile, I want to give you a small advice, okay, Yanni?
Yeah.
Before starting your next implantation, have a good look at the previous one. See exactly how you started it, and just take it the same one exactly with 2 millimeters deeper. That's all. Otherwise, you're going to have another implantation the same.
Yes.
No,
definitely.
show the beginning. That's it, okay? So you see where you started? It looks like pretty deep, right? Well, probably it's not. So you start like this, but just take another 2 millimeters deeper. That's what I would have done.
Yeah, definitely. And we have to keep in mind also that the pigtail is not in the designated position. It's a little bit high.
Don't look at the pigtail. You have a calcium there and steady.
I know. So maybe we can make a film here. Of course, now we're too deep. So, but let's start a little bit here. I think it's fine here. We will start. Yeah, deeper than we normally do. Πάμε 120. Okay. Πάμε 80. Το κράτησες μαζί, ναι. Okay. That's film. A little bit better. Ωραία, πάμε πάλι αριστερά. So the
Go to
AI
LO
looks
caudal.
better.
You go to LO caudal to show us.
Yeah. No, we still have.
Maybe you can deploy in this angle.
Yes, maybe we'll do that. I think
So
we
we
should
talk a lot
deploy.
about cusp overlap and deploying in areocaudal, but this is a unique anatomy. We come in a very different
Okay.
angle with the
Okay.
volute and the anatomy of the patient, and here they are perpendicular.
I think we'll deploy. Πάμε, τράβηξε λίγο το σύρμα, πάμε 140. Ναι. 150. Λέμε σταθερή. Μέσα αυτό εδώ.
It actually came to a nice place.
80.
It's just underexpanded. Yeah.
Now, before taking out, you look at the orthogonal position to see that you're
Πάμε λίγο από την άλλη
expanded.
μεριά.
Before taking out, have a look at the right orthogonal.
I think it has been.
Okay,
It's fine.
okay. You don't see, but the guys from Merrill are sitting here and laughing because the Merrill implantation is so boring.
So what?
So boring. It's so easy.
This happens for all the balloon expandable, or it's only for Mary?
What?
It's
What did you ask?
so it's for the other balloon expandable valve as well, or it's only for Mary?
Yeah. No, I mean balloon
Specific.
expandable. Balloon expandable is boring.
Πάμε λίγο, φτιάξτε λίγο το.
We cannot take out the hemodynamic benefit of the supraannularity.
So there must be AI because but maybe it's a bit that expanded, and there is interaction also with the wire. Let's see. Πάμε λίγο να γράψουμε την.
Very nice.
So the position is nice.
Position is excellent.
But maybe we'll need to see the. So I would like to ask you if you. What do you do to investigate the longevity of the valve? Would you try to see the circularity of the valve? Would you do echo? Sometimes what we do, we try to see if there is circularity. Οπότε πατή να πάμε λίγο αριστερά. Πάμε αριστερά. Yes.
Look, you have a very nice hemodynamics, if I see correct.
Ωραία, θα πατήσω. Δεν θα δώσεις και θα γυρίσω από εδώ. Yes, Ari.
We see very tiny the hemodynamic. So if I see this correct, the hemodynamic looks good. It looks like there is no AI index, bad one. etc. The injection doesn't show us significant AI. The patient is 88 years old patient, right?
Yeah, 88.
So
Would
what are you looking for? Jesus Christ. You have a wonderful implantation. And I'm sorry, I'm not going to die of modesty, but I'm going to insist on learning from this case, what I said in the beginning. Have a look at the first time you had in the LAO caudal. You'll see that all three implantation were completely the same. Am I right, Dr. Mariano?
Yeah.
And what I'm trying to emphasize is that LAO caudal is the mirror of cusp overlap. And it always shows you that you are much higher than what you are. And if the first injection you did in the LAO caudal showed you that you are on the zero, and it showed you that, it means this is the position, period. You understand what I mean?
Yeah.
And this should be a take-home message. Thank you, Professor Finkelstein.
Good. But maybe we can measure a gradient, just make sure, and then we'll take from there. Έχουμε το θικάρι, παιδιά, λίγο. Έχουμε το θικάρι. So we'll take a gradient. And of course, as Arik said, we always have to take into account, of course, the specifics of the case and of the patient. So it's an 88-year-old lady, symptomatic, of course, but maybe doing a risky, let's say, post-dilatation or something to increase the risk of cerebrovascular accident or a stroke. That would be something that should be available. But we need to take care, of course, the best hemodynamics possible. So now we'll place a pigtail, measure a gradient, and then we'll take it from there. So, Danny, are you worried at all that with this slight other expansion of the frame, as we can see, in the cusp overlap?
It is underexpanded for sure, and now it's a clinical decision. What do you do with an 88-year-old lady that doesn't have a problem with hemodynamics at the end of the procedure? Do you search for durability in that patient? And yeah, it's clear that
you see there is some gradient, but of course it's you have LVT obstruction as well. Let's with 0, then we'll take it from again. So there is some gradient. I think we need to do a post-dilatation.
Okay.
Arik, do you agree with that?
I don't know. I would do a pullback and see whether the gradient is correct.
So you were correct as always, you see?
Not always.
So we don't have a proper measurements. There is some discrepancy as well.
You see the gradient remains the same.
So we need to...
So it's not a gradient.
Which balloon do you plan to use?
Well...
the same?
So it's the same balloon, but let's see. Maybe we have some issue with the pressure. Maybe the pressure was not correct after all.
Yanni, can you show us again the views to convince us that it's not fully expanded?
But let's see. So now we need to...
now it looks expanded in this view, okay?
But let's see. So now we're measuring again. So it's now there's no gradient anymore. So there is the magic, the magic correction with putting some saline and flushing the catheter. That did the trick. So now with this information, would you still predilate, postdilate? Danny?
I won't predilate from the beginning unless I'm convinced. Again, there are patients that the cost benefit pushes you to postdilate. And there are certain patients, like Danny said, 88 years old lady, the hemodynamics looks beautiful. And I don't see under expansion so far. What you have seen before might looks now much better because it's a self-expandable. So I'm asking to show us in the perpendicular view of the valve to show us that it's not fully expanded. And when it is expanded, I won't touch her.
Yeah, probably if you go to eleocranial, all of us will feel much better because you'll see that it's very, very wide.
Eleocranial is beautiful.
It means that the valve is oval in a way. Go to eleocranial and take a fluoro and we'll see that the bottom is much wider than what we see here.
Eleocranial, cranial.
Yeah, perpendicular eleo, high eleo.
Είναι eleocranial. Δεν μπορεί να πας. Μη δίνεις. I think it's okay,
Yeah.
but it looks okay.
No, academically speaking, we sometimes do, because you don't have numbers to understand exactly what is the size of that evolute at the entrance, but IVUS is a peripheral IVUS, can quickly give you like some science around what is the expansion. And we do it from time to time, especially in self-expandable devices, with the decision whether to post-dilate or not.
Yeah. Okay. So we will make a final shot. I think that will be the end of it. That's it. Hello? So we gave all our dye, but I think it's sufficiently now. As time goes by, this is a self-expanding platform, so you have better position right now. We're going to make a final shot, but I think we are fine. I think we'll leave it there. Are you okay with that, Danny?
Yeah, for sure. Later today, we're going to have a presentation on implantation depths of the Evolute platform. There is a recent publication that we did in JACC intervention.
Okay. So the satellite symposium of Medtronic starts in a while, but now we have two, concise talks on TAVI on younger age, and I'm saying goodbye for now, and then I'll see you soon at the Eugenides Foundation. Okay, so thank you for everyone involved in this case. Hi from us, and we'll see you later at the conference. And there is another live case by Dr. Voudous and Dr. Sbarouni later on today. So thank you very much.
Thank you so much.
Thank you for beautiful case.